Thank you for joining this session. So I basically, originally I come from Bulgaria, have lived in the USA for 17 years. I studied psychology and then I followed counseling and I became licensed as a marriage and family therapist. And I happened to fall in the field of eating disorders. It wasn't a plan. I just was looking for a job, and I think God has his own plans that we don't always understand. It just comes back to that. So I worked at the so-called Hearth Center for Eating Disorders for 3 years in Columbia, South Carolina. It closed. Then people usually get stressed when jobs close, and I just said, God's will be done. And I received a phone call without even applying at a place where it was called Sella House from Indiana, and they said, we're a Christ-based center. Thank you. We're a Christ-based center. We treat eating disorders. We would really like you to work for us. So, glory to God. I was excited. I worked there for about a year, and most recently, Sella closed in Columbia. So, okay, God is getting me through from one place to another. Within 2 weeks, I found a job in the so-called Eating Recovery Center. So next week, I'm moving to Greenville, and I will be working there again as a primary family therapist, treating eating disorders. I call that a healing presence because I really believe that all of us Christians, in a true kind of Orthodox way, it's our kind of mission to God to be a healing presence wherever we go. And so working for a Christian center helped me, for my own sake, to see that they are the believers, but going out there in the secular world, it's scary or threatening to, in some ways, but on the other hand, it's just another opportunity to, again, communicate Christ, be and see Christ in others. So that's kind of overall where I am, where I've been. And eating disorders, I had a supervisor who used to say, whoever knows how to treat eating disorders, they can treat anything. Now, it's scary to say that, but what I came to understand is that they really comprehend all mental health illnesses, biological, psychological, social, and then add to that the spiritual aspect. It really is a complex field. And I had no idea that I was going to understand it or be a part of it, but now I have I'm scared to say passion, but it's taken my understanding, my attention there. How many of you are familiar with eating disorders? Okay, that's really nice. More than I expected. So then that can be more of a collaborative kind of way, I guess. What I'm going to do here is I will present overall just the eating disorder diagnoses, and then I hope to share some treatment aspects, if I can say, of what has been working in my experience, what I've used in my years with this population. To begin with, I chose this prayer, and I'm just going to read it out loud to you. So, my Lord, I know not what I ought to ask of thee. Thou and thou alone knowest my needs. Thou lovest me more than I am able to love thee. O Father, grant unto me, thy servant, all which I cannot ask. For a cross I dare not ask, nor for consolation. I dare only to stand in thy presence. My heart is open to thee. Thou seest my needs, of which I myself am unaware. Behold and lift me up. In thy presence I stand, awed and silenced by thy will and thy judgments, into which my mind cannot penetrate. To thee I offer myself as a sacrifice. No other desire is mine but to fulfill thy will. Teach me how to pray. Do thyself pray within me. Amen. And the reason I chose this prayer, it's one of my favorites, is also because in eating disorders, in order for us to treat eating disorders, we have to really understand what happens there. What is the world that that person lives in? And indecisiveness is one of the major themes that has popped up over and over and over. And it hit my personal indecisiveness over the years. And this prayer basically surrenders control to God. So I've used it with my patients, among other things. So here are some of the objectives, like I mentioned, that I hope to cover. We'll talk about myths versus reality, eating disorders 101 I called it. We'll talk about the core feelings and overall healing approach, good versus bad. I like to talk about food and fasting when we address eating disorders. There may be a lot of misunderstandings there. Martyrdom, assertiveness, obedience, collaboration, sin, relapse, the hungers, then body image. So in my years of experience, I developed higher levels of care, intensive outpatient, partial hospitalization I led, family intensive I led, and also body image and trauma, and so some insights I'm going to communicate here. And then healer self-care. They say that there is a very high rate of burnout working with eating disorders. So that's why. So myth or reality? Typically we hear that people kind of have this idea when they hear eating disorders, they think you have to be skinny in order to have an eating disorder. The mother caused it all. It's not a real illness. It's all about eating. Only adolescent girls get it. It's about vanity. Eating disorders are the same as addictions. Nobody dies from an eating disorder. It's just a phase. In reality, eating disorders constitute the highest mortality rate from all mental health illnesses. And that's scary enough. I just wrote some signs and symptoms. We all are aware of food rituals, isolation, spending too long time in the bath and shower. Why? Because of purging behaviors. People will isolate and use Ed behaviors there. Ed stands for eating disorder, right? Excessive chewing gum. That's interesting. Oftentimes when I share that with families, they're unaware that drinking coffee, chewing gum, what it does is it just suppresses appetite. So they're thinking they're going to not eat, lose calories, not gain weight, so forth. Be in control, ultimately. Sugar-free candy, that can be used as laxatives, actually. Food wraps, they can just leave them all around. So the family will end up finding open wraps of snacks and get really upset and think that the patient or their loved one is trying to, is seeking revenge or trying to kind of spite them, when it's not necessarily out of volition. It's not, there are a lot of other things going on underneath. So, the main diagnoses, like I mentioned, I just wanted to kind of go over them. We are all familiar with anorexia. So we know that this is the classic eating disorder where people look very skinny, they lose weight, they are controlling the food intake. So mainly behaviors are restriction. There is a subtype of anorexia where they may binge and purge, but how you may how you can make the difference between anorexia and bulimia would be, one, anorexia in the onset, the child typically has more anxiety. They're the shy kid, and as they grow up, they get bullied, or just society suppresses them, or they're just talking, they hear the general culture's idea of dieting, and this is where statistics that say 1 out of 4 people who diet develops an eating disorder applies to typically that case. So we all know of serotonin and dopamine. Serotonin is the neurotransmitter mainly associated with regulating our fear. So that will go with anorexia. Again, generally speaking. Bulimia, on the other hand, starts with obesity in the onset, then bullying or trauma, and so it has more in common with addictions. Are eating disorders an addiction? Google will say yes. And their behaviors look like an addiction. However, there is a difference from an eating disorder to an addiction, and the main difference is somebody addicted to a substance has to stop that substance forever and ever. Somebody with an eating disorder can never stop from food. They just have to learn to moderate it. So in a way, they have to learn to, it's scary to put it that way, but they have to learn to identify the devil and have some interaction, keep him out of, but he's the invisible force here. So it is very tricky. So again, anorexia is more about anxiety. They're shy, they're withdrawn, they will restrict. If they try to binge and or purge, they typically don't like it. A binging session for them will be something like, let's say that they survive on 300 calories a day and they ate an extra a piece of cake, and they call that a binge. Or they might really, it's just rare, it's not a major thing. With bulimia, though, those binging, purging episodes, again, they look like a trauma kind of cycle and addiction cycle. They feel down, low, and the behaviors give them a short high, and then they plummet. And again, they feel that depression, and again, they, binge purge, they feel a short-term kind of elevation, and then again, things get worse, and it's a downward spiral. BED stands for binge eating disorder, so again, trauma is very highly correlated with binge eating disorder, and typically people start with restricting food, and they end up overeating. And the problem is that our bodies just need to eat. And so here's the tricky part. What do we do when we fast? How do we understand fasting? Well, and I have included a slide on that later, but fasting is not a diet. It is not about self-chastising. It is stopping a habit. And so if the person has an illness, their fasting should be moderated. They first of all should speak with their father confessor, of course, and they can fast from their guilt. They can fast from their whatever their specific behaviors are. Usually people will restrict so-called evil, bad foods. They label that. They think that foods that contain sugar are bad. They think that foods that contain fats are bad. But guess what? Fat feeds our brain. We need that. We need sugar for energy. We need a little bit of everything. So truly, in a way, courageously, I can say that fasting has nothing to do with an eating disorder, and no, it doesn't lead to an eating disorder if people fast correctly. But it has, and again, it's not about it's not about power control stopping. It's about being obedient. OSFED is so-called other specified feeding and eating disorders. It used to be the old name for NOS, not otherwise specified, so they have a little bit of the anorexia kind of behaviors, a little bit of bulimia, but not exactly, not for as often. Those behaviors don't occur as frequently as they would in the classical type of anorexia, bulimia, and binge eating. We have RFID. I just included that because I wanted to also share that's a new one. So it's avoidant and restrictive food intake disorder, and it has it's always existed, but it was most recently identified as such. It exists mostly among boys, and those boys, it happens to girls as well, they don't want to necessarily lose weight. They want to gain weight, but they can't. So it's more, it has to do more with an aversion of the taste buds. When they taste food, they might get a gagging effect to it because of the texture of the food, the smell of the food, anything that has to do with their senses. So they're extremely sensitive to the physical, again, experience of food. And I included orthorexia nervosa out of curiosity. Have you heard of that? It's really a curious one. It's about eating healthily. It's not included in the DSM manual yet. However, there is a lot of research written on that. And the problem with eating healthily, first question is, what do we understand by healthy eating? And the second question is, what are the fruits of that? So a lot of people might say, well, healthy eating for me is just eating lettuce. Well, that's very similar to anorexia, restricting. But a lot of people nowadays go and only shop at organic food stores. They really restrict their diet. And so what happens when it is a disorder, a diagnosis, they really end up restricting to where they're not even going to accept food at a social place. So it ends up, again, with under the label of power control. It's a totally different phenomenon. It's not about the food. It is about food, but it's not about the food. So here is the eating disorder vicious cycle. I mentioned it earlier, but you can see it more visually. It starts with a diet. It starts with restricting, basically. They just say, I'm not going to eat so I can have control over something. And then they're craving food, they get hungry. The body naturally will feel that. And so if people lack support, spiritual depth, if they lack, if they isolate in that way, if they are not sharing with others, if they don't have guidance how to, I'm referring right now to fasting, for example, how to do it, they might slip down that slippery road. And it might end up leading them to binging, which in their mind they interpret as I lost control, so I am unworthy. And then they will, if they purge, they will have a purging cycle. It talks about weight gain here. If you can see, a lot of people think that by binging and purging they will lose weight, but they actually end up gaining weight because purging itself is just dehydrating, and it just makes people lose fiber and water, basically. It leads all the way to guilt and shame, and they just say, well, next time I'm just going to do this better, and I'm going to try better at this because I'm such a worthless, bad person. So again, my hope is that we can understand that whole cycle and the inside, so we can walk with them through that. They feel so much shame that they're resilient to even sharing that, to even talking about it. What leads to an eating disorder? So no one causes it, even though people end up blaming themselves and each other. But there are contributing factors, and here's when we talk about biopsychosocial. But I do like to add also that we live in a hostile environment, and that's where the world is just not a safe place. When we turn on the TV, we see advertisements. When we go out, even on the street, there are billboards, and they communicate messages about what we should look like, what we should do. And so that's what this relates to. And so the biological background is eating disorders do run in families. There is a genetic background, but it's not the main cause. It's just that it's frequent there. I already mentioned serotonin and dopamine kind of playing those roles earlier. The psychological part says that it basically refers to the fact that if you imagine, you probably are familiar with the iceberg model. If you imagine the iceberg plunged into water, on the tip of the iceberg, we see the behaviors of the eating disorder. So the person isolates, okay, they restrict, they binge, they purge, whatever they do. Underneath, however, there is trauma, probably post-traumatic stress disorder. There is depression, there is anxiety, obsessive compulsiveness, and we talk about obsessive compulsive personality traits. It's really not necessarily always a diagnosis. In fact, it's hard to give them a second diagnosis, because a lot of times if people have starved so much or they've used the eating disorder behaviors so long, it can give them kind of like side effects of the particular illness. And unless they are restored and on the right track of eating, we can't, again, affirm necessarily. Like, it's just difficult to give a secondary diagnosis. And substance addictions also go here. Socially, well, any kind of major change, trauma, relocation. There's research that says that people who relocated from Greece to Britain developed eating disorders by far. And just thinking about it, okay, what really happened there? They move from one culture to another. They're experiencing a new identity. They just have to change the self. So the internal messages are, I should be different from what I am. So it just raises up a lot of questions about, what did God create me to be? Who am I? How are we free? How can I be myself without hurting myself and that consciousness and others, basically? I just included a little list here of consequences to the eating disorders. Like I mentioned, the very last one is death, but organ failure, basically. And you can just read, it's scary. And typically people will just say, oh, nothing major happened to me. I just got dizzy, or I just, fainted a couple of times. But I've had patients who ended up in the emergency room. Basically, their parents thought they were dead because of what they did. Something people underestimate is that every single binge purge cycle can lead to death. There is no guarantee. And so that's why, the death rate is so high. Not so much that the eating disorder itself directly is killing them or something, but they isolate, the behaviors are risky, and they also do a lot of self-harm. That at least the rate is very high. So is the real illness? Yes, it is a real illness. And just for us to be aware of that, I'm going to skip that. So in family intensive, I used to invite families for 3 days, up to 3 families at a time. And we used to talk about roles. And those are metaphors. They come from the so-called Maudsley model, originated in Great Britain. And they would, basically, they gave those roles to families to be kind of playful, but also as a wake-up call. So the ostrich are people who in the family would put their head in the sand and not communicate any emotions. And that's very common with, again, eating disorders. The jellyfish is the opposite. It's the one that is projecting emotions so much that it's biting and stinging everybody. They're also blaming and they're experiencing everybody else's feelings double, triple. The Saint Bernard dog was their metaphor for I'm there for you. So it's our, how can I say, model of how to be a healing presence. Is the metaphor that says, basically, I'm not going to judge you. I will stay neutral, and when you have, an emotional breakdown, I will hear without saying anything. So this is the point where we're not agreeing with what the patient is saying, but we are with them, just that healing presence. And so I come back to being a Christian presence. I imagine just Christ kind of holding their hand and kind of just grounding them, basically. I'm here when you need me. Call me when you need me, but I'm not going to push you, especially in this moment. So the other 3, the kangaroo is sometimes parents will, and practitioners also in treatment, will put their loved one in their pouch and say, no, we don't have to talk about this. And so they don't take any action. That's detrimental. It ends up kind of patting them on the shoulder and fuels the eating disorder, the illness. The opposite is the rhino, which is kind of head first. They start, in a way, getting angry and shaking them to reality. So the eating disorder murmurs in the person's head, you see, they all hate you, you're worthless, so you might as well continue with what you're doing. So it doesn't do it any good. The dolphin is, again, the playful metaphor that describes the healer, the healing presence, as somebody who watches from afar, and we will not carry them on our back, basically. But when the person is really suffering, so they are using their behaviors, maybe they didn't join us at the table for dinner, maybe they left right away and went to the bathroom, maybe we found those food wraps, maybe we saw that they're losing drastically weight, go and address that one-on-one in a loving, respectful way and say, I observed, I noticed, here are the facts, I'm concerned about you. And we have to take that first step. Very rarely will you see, or at least I haven't seen, people with eating disorders voluntarily really go and ask for help, at least not initially. Later, after several cycles of relapses, they do, but it's hard. So to summarize it again, we have to do that first step, and it is tough for us, and we just have to do it in a neutral kind of way. So I just added this as cognitive distortions and personality traits. The devil is the accuser. I remember when my father confessor and I had a conversation about this, and it kind of dawned on me, and I thought of eating disorders. When they blame themselves, they're really siding with that eating disorder, with that kind of evil side. And so the patient is not evil. They are the human being. They're, God's child. But they get these thoughts, these convictions in their mind, and sometimes they believe them and sometimes they don't. So personality traits, again, on the surface of our iceberg model, there is perfectionism. When we talk about eating disorders, low self-esteem, high conflict avoidance because of that anxiety, people-pleasing features. So that's very tricky. They may appear to us as very loving, and they just don't want to raise up any havoc, and it might be very difficult, especially when we all strive for a positive quality like this, it would make it even more difficult to recognize that that person may be carrying this illness within themselves. Why they do people pleasing, however, is the motivation behind. The motivation is anxiety. They're just afraid of conflict. Black and white thinking, they're just stuck between, either or. Either I'm going to be skinny and happy, or I'm going to be fat and unhappy forever and ever and a failure. Either I'm going to diet perfectly, or I'm going to fast perfectly, or it's never going to work out for me. So we have to really move and challenge that. And so we have to create a safe environment into which we end up challenging that kind of mentality. Cognitive rigidity refers to the same. And then self-harm. So purging is a type of self-harm, even though that population will cut also. There are many different forms of engaging in self-harm behaviors, but purging is one of them. Ed the Invader, this is the Venn diagram that they use just to show that if the green circle is the person, the blue circle is the Ed, the eating disorder, it just overtakes the personality. That's the internal voice that they will engage in. Worthless, you're a burden to your family, you shouldn't have been born, you deserve to be punished, you're a mistake, you'll never succeed, you'll never be able to recover and be normal, everybody is against you, no one understands, and the list just keeps going on and on. I included the 7 core feelings because for eating disorders, those are the most prominent, and I used to write them on the board usually during activities so they could identify, because with eating disorders there is the so-called aphasia. They're just unaware. There are studies done where people will look at pictures of people smiling or serious or just different emotional expressions, and the one with eating disorder cannot read correctly the face. They will see somebody serious and they will interpret it as they're angry, they hate me. They see somebody sad and they say they're mad at me, or again something judgment related. So what goes on again within their emotional state, and they are suppressing that, is fear, pain, loneliness, anger, guilt, shame. I included joy because there are those moments again that it might be false short-term joy, or it might be the joy they're striving towards, but again they're familiar with that. So who is the healer? We say you can do it, but you can't do it alone. You alone can do it, but you can't do it alone. That comes from the Maudsley's writings. The whole treatment team consists of clinical therapists, recovery therapists, RCs, registered dietitians, psychiatrist, physician, nurse, the family, and spiritual father. I think that all of these, nobody is more or less. I think people just try to do it on their own, or they say, I just have a therapist and that's enough for me. And it's not. With an eating disorder, the eating disorder has to be attacked from all directions. Christ is the ultimate physician, so when I enter sessions and things are so challenging and hard, there are many times when if I tell the patient what I really know, I'm already in conflict with them. They don't want to hear it. If I tell them what my diagnosis or prognosis is, that's already a mistake. Many times I just sit there and I pray. And sometimes within conflict, just miracles can happen, or just it can clear the moment. But silence is important, prayer is important, and along with that, stating the truth, communicating what your observations are. You look like you're really sad right now. You look like you're confused. I observe these behaviors and that worries me about you. That concerns me. And you're not alone. I'm here with you. And through all that agony and sadness. I added this icon, using the paralytic. So the healer, some guidelines. I just added some of these kind of thoughts, but I thought, structure is important in eating disorders. There are many therapists who say, I'm an eclectic therapist and I'll just do whatever I know, a little bit of everything. When I started working, I was trained pretty well, probably, give or take, in experiential and art therapies. I loved that. And I was disappointed to see that that was not the best approach solely, only, with eating disorders. Instead, I had to use CBT and DBT skills and something else that I was bored with. So I ended up appreciating this. So the structure helps people who have this illness find, how can I say, find their way through the chaos. Everything does not go. There is a certain way that they have to be approached, a certain way of treatment. I said discipline. That also has to do with the structure of their meal times. So in the higher levels of care, their meals are scheduled. 8 o'clock until 8:30, breakfast. Then they have, 2 hours later, they have a snack for 15 minutes. Then they have a meal for 45 minutes, from 12 until 12:45. Then they have another snack in the afternoon for 15 minutes, 2 until 2:15 or so. Then they have dinner again for 45 minutes. Then they have a late evening snack, and every single day it has to be the same structure. If we break that structure, we risk their anxiety is going to go up. Those behaviors and thoughts again resurface, and it goes back to. So, but what goes to discipline is also prayer. For us to kind of teach a healthy way of disciplining somebody, it's what wouldn't be more wonderful to wake up in the morning, say the prayers, have some breakfast, continue with the day, then do the next task, go to service when we can. I think that nowadays a lot of people mistaken that with obsessive compulsiveness, and we just have to be aware of it. OCD is a false way of trying to keep control over things. Discipline is something that we, in our kind of nature as human beings, need for sanity's sake. That we're just programmed to live in structure. Without structure, we fall into chaos. But for the healer ourselves, I also was thinking how important it is for us to attend, to do what we preach. That's why I came up with all these things as well. During the session, saying those prayers, I can't even think of how many times just sitting there and grabbing my prayer rope in the session and just thinking, okay, I have no idea what to do with you. No matter how many licenses or how many degrees I have, it just crisis intervention doesn't work that way. And it just kind of, we keep on going and things work out somehow. That was just a quote I wrote in Bulgarian on the top, but first God heals, then the doctor. But the one who does not thank the doctor, he doesn't thank God either. He who works is worthy of his reward. The mind and the hands of the doctor accomplish God's will. So I'm going to go a little quicker through these so I can show you some examples of treatment approaches that I've done with the patients. But this article is really interesting, and you probably already are familiar with it, by Father George Morelli on eating disorders from an Orthodox perspective. So I just basically, what I added here was that we have to think from a holistic perspective and include all different fields in treating eating disorders. So is food good or bad? That is where the black and white thinking comes in. And in the Bible we have, in Genesis, some of the scriptures which, not to rely on them, but in the same token they can be motivations for patients with that particular illness, that say that every moving thing, that everything basically is allowed to us to eat except for bleeding meat. Well, cook it and we can still eat it. But that comes again from a perspective that somebody with an eating disorder is blaming it on food, blaming it on all those ingredients, and we just want to counteract and explain to them again, bring them to a level-headed consciousness, using what God would say. I spoke about fasting. So, okay, here's one thing that I did once. I opened a so-called spiritual group, and I was using basically the Psalter. I was using a lot of Orthodox kind of ideas and saints, and that one day I asked them about their different hungers, and it really turned out into a wonderful discussion. So just to be aware that people have physical signs and needs, hungers, mental, emotional, and spiritual. So physically, If we're physically hungry, we're going to have that churning stomach ache, salivating. What do we need? Food. Mentally, if we're mentally starving, then we're going to feel irritable, impatient, aggravated, crestfallenness, despair. What do we need? Maybe one-mindedness, clear thinking, honesty. Maybe that's where we go to confession. Emotionally, when we're hungry, the signs are impulsivity, urges, numbness, frustration, anger. The need, love, peace, acceptance. Be surrounded by the people who offer that to us. And spiritually, again, you can see meaninglessness, listlessness, loneliness. What do we need? Prayer, confession, just get more in depth with the spirituality. But the main idea here is that what ends up happening is people have a mental, emotional, or a spiritual need, and they try to fill in that gap with the food. That's really what it leads to. So for them to learn to discern is important. I included a little bit on martyrs, and you can kind of read for yourselves. There is a difference between the Ed martyrdom, eating disorder martyrdom, versus the Orthodox Christian idea of martyrdom. The eating disorder sends them to hate themselves, punish selves, blame others, avoid the truth for fear of conflict and judgment, refuse help, isolate from others, impulsive actions, disagrees and rebels against advice, withholds the truth, white lies used, often reaches out for self-harm and death. Whereas the Orthodox Christian martyrdom, very frequently misunderstood nowadays, hates sin but loves all of God's creation, confronts demons in pursuit of the truth, fears only God, thus courageous and assertive, seeks help, recognizes that no one is perfect and the ultimate physician is Christ, communes with and prays for brothers and sisters in Christ, acts according to church tradition and canon law and spiritual guidance, practices obedience first to God, confesses personal sins. So there's this openness basically in there, witnessing the truth. And it didn't show here, but I was basically saying that witnessing the truth, this teaches us healthy assertiveness. Our martyrs didn't die because they killed themselves, they died because they were martyred by others, not they stood up for the truth. So this is something to bring up to people who entertain eating disorder kind of mentality. The ladder to my understanding, this is an icon I've often given them in that spirituality group and asked them to relate to it. Where do they feel they are in their process and progress in recovery? And then we talk about, again, that nobody's perfect. To fall down doesn't mean the end of the world, but get up, talk about it, repent, right? And keep on moving. So make an opportunity of relapse is how we want to address it when we talk about eating disorders, rather than avoid. So interventions. Is it okay if I share that? Okay. So here's just a list of overall things that we have done so far in the facilities I've worked at. Meal outings. They learn how to order at restaurants and how to self-serve, eyeball the food. Equine therapy. Horses is really interesting how sensitive they are to people's reactions, and they're emotionally reactive. So when we're reactive and the horse is reactive, we have a little battle there. So we have to learn to interact in a peaceful way with them. So a lot of therapy has been done with this, and that's a totally different chapter, but just for your idea, this has been used out. Clothes tryout, I've taken them for body image experientials, mirrors viewing, body tracing, and you'll see some of these a little later. Here are groups that I mentioned. Okay, body image. So here's a quote that my patients came up with, and I loved it. But the Lord said to Samuel, do not consider his appearance or his height, for I have rejected him. The Lord does not look at the things human beings look at. People look at the outward appearance, but the Lord looks at the heart. So negative body image, very similar to the eating disorder itself, has specific internal thought, judgmental voice, feelings, and behaviors that send the person to a downward, self-devastating cycle. I often talk to them about Christ's two natures, divine and human, and the temple of our bodies. But instead of just talking, we do also art activities. So here's an intervention of the body tracing. This is a specific one. It's only to be done one-on-one with a patient. And what happens is I give them this big butcher paper and I ask them to outline what their internal voice tells them they look like. And then in black we write their thoughts. So they might say, I have men legs, I look like a cookie or something, and they have all these negative derogatory words. And then I process with them and ask them to lie down, and then I trace them in a different color pen. And they are way smaller than what their initial drawing was. So then we start talking. Oftentimes the patient will say, well, somehow you lifted me up, or the pen must have gone underneath. And what I'll do then is I'll use a string. I get yarn and I give it to them and I say, okay, how big do you think your stomach is? How big do you think your thighs are? And they make this huge circle like a hula hoop. And I give them the scissors, I don't touch, and then I give it to, and I ask them, now put it around your waist. So they measure, they cut it, and they see it's probably 3 times smaller than what they thought. Now this works with anorexia, not with bulimia. They have to have really, major distortions with the way they perceive themselves. This is called the body feelings map. So they draw an outline and then they write a little legend and color in with emotions, and then they add them inside their body, how they experience that. And then we do a little breathing, prayer exercise, and then basically I direct them to follow the pain in their body and focus on the pain. And then they ask 5 questions to the pain, and those questions are meaningful questions. They have to do with asking the pain, who are you, what do you feel, what are you here to teach me, basically. And they come up with insights. So in the past, whereas they used to avoid pain, now they understand that they can sit with the pain, learn from it, and grow out of it, get freer. We do little clay animals and talk about, this is the string example of what it looks like. I'll skip family intensive program. And here are some arts. With family, what I do with the family intensive, I give the family an art project and I ask them to each express what their personal experience was with the eating disorder before treatment, and then after treatment, what their hopes are after treatment. And it's amazing, as you can see, this person here drew this up kind of hill. It's a skull in the very end. They were seeing death, and the way they share that fear about their child dying, they've never spoken about it before. This is the first time they usually open up at this activity. It brings up a lot of, the can with worms. And then the second drawing is this particular parent's hope that they can all, like trees, gather around this peaceful water circle and commune, just stay together. They will come up with many different metaphors. This was like a bundle of elastic bands that they couldn't get. They were all in a chaos. They couldn't organize them, and then they wanted everything to look like the rainbow of hope, basically, and be able to share emotions. This is an interesting drawing here. This was a dad whose experience was like he was dead because nobody in the family would listen to him anymore. Everybody was doing their own thing. Chaos, and he wasn't able to help them. That was the first time his daughter saw him cry also. And again, talk about sharing feelings. This was a major change. Usually they'll portray the eating disorder like a tornado, and they call it the demon, patient's words. So I will skip. This here is an activity that I use. I used in the spirituality group, and I called it the cross of forgiveness. And basically in the middle I asked them to draw their conflict. What are they holding that they cannot forgive? Usually that's their body. They hate their body, they're angry with themselves. And the left corner is the part about, okay, what was your life like before you entered into this conflict with yourself? The right is what happened after this conflict. In a way, it's the trauma also. So this person drew this downward spiral. They were just lost in the middle of the cross. In the past, it was just this beautiful, green, peaceful land, the light, a lot of different colors. They used to like art, is what they did, that palette. On the right, they added the black and white thinking. They said that the eating disorder really began splitting them from others and within themselves. Then we talk about Christ going into death, and we have to talk about them burying some of the things that they don't need anymore. So a lot of patients have never heard about this part from the Bible. They get excited about this, that God exists everywhere and he burst hell, right? And before the resurrection. So that helps them kind of find peace from all these, how can I say, messy thoughts and experiences. They end up choosing the things that are not necessary, and they bury them, they leave them in the past, and then they resurrect how they have become a better person thanks to that painful experience. So at that point, they make goals, or they just recognize, this person recognized that they have been really forgiving. There was forgiveness there. They will usually write freedom and their family. They want to be closer with their family. And it's amazing just what insights will pop up from just a few of those drawings there. I give them the so-called blessings bags. So in this group, they would collect insights and prayers and wisdom words and throughout the recovery kind of period of time, and then I give it to them with a flame, so-called the wrapping paper, a flame of inspiration, so they can keep their hearts aflame in the future. So now I come to the healer self-care. Christ being the physician, pursue active and open collaboration with the treatment team. It's really important to prevent burning out, to rely on our own kind of support system, basically. There is a lot of splitting, just like the patient with an eating disorder will split in the family, they will split the team and split within themselves as well. This black and white thinking, I love you and I hate you at the same time. That is not of them, but it is a symptom of their illness, and we just have to be aware of that and not work with it. Follow church tradition about prayer, practice what you preach, and I kind of mentioned these things. Trust the spiritual father's guidance, know your rights as God's creature. So basically we have to be able to demonstrate assertiveness and healthy boundaries to them. Maintain community with fellow worshipers, abide by your professional knowledge, stand, I say by the can, Holy Fathers, we, with eating disorders, we have to follow what, that cognitive behavior therapy has been really well researched, and it's the only and best way that works with eating disorders. And we just have to include that. We have to include dialectical behavior therapy. Just be very aware of these. Like I was speaking earlier about the whole treatment team. There are many people who exclude a dietitian from the treatment, but yet they are one of the primary resources when we speak about eating disorder treatment. Follow not personal agenda, God's will be done. I just, in like closing words, eating disorders do really bring us this fantasy that we are in control, and not just our patient, but even they can mesmerize even the practitioner and the loved ones. We end up thinking that we can help them ourselves, and really we can't unless they want to change. It's a collaborative effort altogether. So nobody can do it alone. Just spoke a little more on assertiveness here because there is so much anxiety that keeps people silent, and they don't express their feelings, they don't express their personal experiences, and they have to be able to get it out, to trust, to have a place that's safe for them, trustworthy. So here are just a few resources. NEDA is National Eating Disorders Awareness, Association. Yes. The SKIDA is a South Carolina-based group. That's where I'm coming from, and they just provide support for free. The Ed, the Voice, one of my ex-coworkers, opened a website where she's sharing, and other colleagues also are sharing insights on how to deal with negative body image, or how to find support during times like Thanksgiving or Christmas, when these are the tricky moments when people are afraid, people with eating disorders are afraid that they're going to overeat and binge and then purge, and the eating disorder is going to return. So that can be very helpful to them. And then I included Eating Recovery Center is where I'm going to Greenville. Sella House in Indiana is a really nice facility that is, like I mentioned, the one that's Christ-based. It's no longer in Columbia, but they're still existing in Indiana, and they can be a great resource as well. And just a few books. The first one in blue and orange is the one that I mentioned earlier, the Maudsley method. They give very specific examples of what to say and what not to say to somebody with an eating disorder. They have a chapter on anorexia, a chapter on bulimia, a chapter on binge eating, and so forth. It's a very handy material for families themselves, but also any one of us that wants to help them. So thank you. If you have any questions.
Hi. You were talking a lot about, it seems the eating disorders deals with like restriction of the foods. How, and does it, maybe possibly the opposite of obesity? And obesity fit in, and I guess that wouldn't be necessarily the restriction of foods, but the lack of control. So that's can kind of, is that kind of considered an eating disorder or different, and how does it fill under that umbrella?
Yeah, that's a good question. So not necessarily, obesity is not necessarily an eating disorder. There are many different other things that can fall there. When we talk about an eating disorder that would resemble obesity, that would be typically the binge eating disorder. And what happens there, it's very highly correlated with trauma, and people will typically again, it's a part, they've lost control. It's a real thing. They've lost control in life, whether it's been some kind of an abuse or loss, somebody's death. So that ends up being projected in a restriction of food. They just want to be good at something, one little thing, and they end up restricting food, but they're out of control. They can't do it. This emotional, again, turmoil is raging, and so that's why. So the truth is, they are out of control. But they blame themselves by that. So when they restrict, the next thought is, I am out of control. They end up overeating. Then they typically they won't purge even if they try. That's not really the behavior there. And so they say, well, next time I'm just going to restrict even better because I'm really worthless, and I'm going to stop myself from going out with friends, and I'm not going to talk to people, and the guilt and the shame are just wrenching at that time. And so the more they restrict, the more their body is going to rage in havoc. And if biologically they are disturbed, psychologically they haven't dealt with that pain, it just sends them to more out of control. And so this is more like trauma intervention. A lot of our binge eating patients, we would correlate, like at the same time treat for trauma, or after the eating disorder kind of treatment, we refer them to a center where it's trauma based. A lot of times it's happened like that. I know that nowadays everybody's talking about obesity.
At the beginning of your lecture, you talked about how certain eating disorders are not addictions because you can't take food away. In the case of bulimia specifically, can't you take away that action, that repetitive, ceremony, if you will, of action of purging, or even in binging or overeating? Can't there be restrictions, not restrictions, but even certain actions that are completely eradicated to help?
Certainly, that's what we're hoping to do. We have to stop the behavior, but not the substance.
Especially with all the chemical reactions that go along with anorexia or bulimia. I'm just confused as to how exactly it wouldn't be seen as an addiction.
How exactly it would be seen as an
It would not be seen, yeah.
So somebody, and I'm speaking specifically about the substance addiction, like addiction to drugs, addiction to alcohol, the 12-step groups, for example, AA Anonymous, Al-Anon, research shows that there is no evidence that they work for somebody with an eating disorder. The tricky part with an eating disorder is that it can be helpful, again, the 12-step groups, but it may not be helpful. If somebody has, for example, anorexia, and they're spinning downward, an AA group may end up actually comforting them while they are starving to death. They have to be in a higher level of treatment and control of more staff. So yeah, behavior-wise, it definitely resembles addictions. I'm not opposing that. What I said mostly referred to the substance, that we can't take away the substance. The alcohol, we tell them you have to stay away from alcohol. You have to detox. With the food, there is no such thing. You can't detox from food. They go to the center and they're faced first thing. In the morning they have a breakfast and then they have the full menu according to what the dietitian has prescribed, which is scary. But psychologically what they go through is similar to the eating disorder. Does that answer? Okay.
Thank you very much for your beautiful talk. The primary care doctors, like myself, probably see 3 for every 1 you see that aren't, God willing, so severe. My question is, when someone knows they have an eating disorder, they get older, they get stressed, and now it's kind of coming back. They know it. As opposed to this huge, big approach, is there kind of an intermediate way to help these people get back on track without getting the whole deal, like you're speaking of, with all the different practitioners helping?
Are you asking more like in the outpatient base?
Outpatient and kind of a almost relapse, a small relapse phase, shall I say? Because we see a lot of those. Like they know they're going that way, so how do we give them a little direction? I don't know. Is there medicine? Is there one person that loves this bit of it?
There is no medicine that I can talk about. Like there is no magic pill, And what's really tricky with, again, say anorexia, for instance, I'm using that a lot, it's been the most researched, is that if the person is significantly underweight, no matter what medication they take, their body's not even going to use it. And a lot of times doctors end up giving them antidepressants, anti-whatever, and they have to have the food, the enzyme that breaks it down. And so it depends on what level of care they need. So I would say in any kind of a case, the first step would be to connect them with a therapist who is skilled in eating disorders. Not every therapist is skilled in that. Even though I took courses in that, I had no idea until I started working in this field, and just one of us professionals. So they have to have an initial assessment. I've seen cases where patients with anorexia, because that's usually the most difficult one they talk about, have been able to do it with the therapist and the dietitian in outpatient basis. Very rarely. For the past 4 years, I saw one single person like that. So it's just too much of a responsibility, of a risk. And I would say again, for them to be assessed, I would send them to be assessed. And at that point, if that therapist says, you need higher level of care, then we're there to support them. If they say outpatient, wonderful. But they have to stay plugged in with the physician, with the dietitian, with the others. It's very tricky. Thank you.
We're actually at time, so one last question.
Hi, thank you so much for speaking about this, and especially with such spiritual depth. I guess one of the things I've often thought of with eating disorders is this sense of aggression against the self and this kind of punishing rage. And that's especially in bulimia, and I've often wondered about that because it's really scary. It's very life-threatening, as you pointed out. And I just was wondering if you could say a little bit about how much of that you see, the kind of sense of rage.
You know, this is what draws always tears in my eyes, and it just pains me because I also hear how much in pain they are when they're raging, and it's easy to get angry at them. What I think of directly is trauma, and I do I don't want to call it trauma intervention because it's not like, you know, crisis intervention at every single moment, but it is trauma treatment. There is a theory that Harvey Hendricks, he kind of wrote about imago theory. It was interesting. He wrote about the brain on trauma. It's one of those advertised books. I'm not very excited about advertised books, but he did have a point there. The brain on trauma, he speaks about the 3 layers of our brain, roughly speaking. The very small brain is the reptilian brain, which doesn't make any difference between past, present, future. It's just basic. Then we have the limbic system, and then we have the mammalian brain. And the third one is the new mammalian. So people on trauma, when it happens, it gets locked in their basic reptilian brain. And so when they rage and do all these things, it's automatic. It's locked in there. No matter how we process, and if they're starving or if they're using behaviors like binge purge, it's fogging their mind. They cannot think clearly. That's why we say that they're sick. So what do? I reflect their feelings. I don't believe that I'm going to make a change right away, but I validate and I validate. And then I push for specific interventions. Like the family intensive program was for 3 days. No parent usually wants to come here. They have to take 3 days off from their work and come and be there from 9 in the morning till 5 in the evening and have this intensive training and therapy. They're brain dead after that. But in the same token, this program gained 97, it was in the 97th percentile of excellence. So what it shows is that we have to push them. We have to validate. We should not show much emotion. I mean, that's the dispassion part of the piece. So it just pulls compassion in me when I see them struggling. And so when I reflect, I will speak to their pain. And I will speak to how this eating disorder is consuming them and it is killing them. No, you're not killing yourself, but Ed is really against you. And I know you want to leave the facility. I know you're calling us Nazi, which really they're, all things we hear. But, I am on your side and I'm against Ed. And I'm going to fight with this demon, until we get you out of here. I want to see you free. I want you to be out of this, system. Does that help? Thank you. Thank you.